Welcome to Same Surgeon, Different Light, Season 6. This is part of the Society of Thoracic Surgeons Surgical Hot Topics podcast series. My name is Sara Pereira, and together with my co-host Cherie Erkmen, we will meet cardiothoracic surgeons from across the spectrum of our rich community. We will explore their journeys, the obstacles they've faced in their careers, and the qualities that make each cardiothoracic surgeon distinctive and valued. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.
Same Surgeon, Different Light is brought to you by the Society of Thoracic Surgeons Career Center, where you'll find free access to cardiothoracic surgery jobs, career development tools, and professional guidance. Visit the STS Career Center at careercenter.sts.org.
Welcome to Same Surgeon, Different Light. I'm Dr. Sara Pereira, along with my co-host, Dr. Cherie Erkmen. We've been looking forward to this episode today. Joining us is Dr. Stephanie Chang. In our podcast, we explore what happens when a childhood dream of teaching meets the high-stakes artistry of the operating room, as we sit down with Dr. Chang. She's the Surgical Director of Lung Transplant at NYU Langone Transplant Institute. From the moment that Dr. Chang discovered the technical cool factor of a CABG in her college biology class, she has been captivated by the surgical precision and its power to transform lives. Dr. Chang reflects on formative mentorship during her thoracic training at Washington University School of Medicine in St. Louis, where the pioneering legacy of lung transplantation shaped her career and helped her find a professional sweet spot between cardiac precision and thoracic oncology. In our conversation today, Dr. Chang discusses performing the first fully robotic lung transplant at NYU, advancing innovation in a high-stakes field, and balancing leadership, mentorship, and motherhood, while still finding joy in reading books, family dinners, and life outside the operating room.
So Dr. Chang is Associate Professor at NYU, Director of Lung Transplantation, and she obtained her medical degree at Duke University and General Thoracic Surgery training at WashU. She performed the first fully robotic lung transplant at NYU in October of 2024, and this really paved the way for other centers to do the same. So, Dr. Chang, thank you so much for spending the time with us and to opening yourself and your story to our listenership. So I would like to start with the beginning and your childhood and to learn a little bit more about where you grew up and what inspired you to medicine and cardiothoracic surgery.
Yeah, thank you for having me, and it's really quite a pleasure to be here with you ladies today. But with regards to my childhood and that, I think I was always just a very literal person. And so from as far as I could remember, I was either going to be a doctor or a teacher because those were the only two professions I ever understood. And I loved my pediatrician and I loved my teachers growing up. But as I kind of went into middle school and high school, I think I just was more inspired to be a doctor and helping patients and doing that. And so I really never thought about being much else my whole life. And then the first time I thought about being a surgeon was actually at this biology class in college, and it was called, I think, like organ reconstruction or something like that. And it was talking mostly about orthopedics and different types of like hip replacements and things like that. But one random thing they talked about was they talked about cabbages for some reason, and I don't know how that came up, but once they actually described what a cabbage was, and then I thought, oh, you can actually sew blood vessels to a heart and reroute blood. I just thought that was the coolest thing I'd ever heard of. And so that's really when I started wanting to become a surgeon, and then was lucky enough to go to WashU where I just had fantastic mentors as well. So, yeah.
That's awesome, Dr. Chang. Welcome to our podcast. We're super excited to have you. You were so high on our list this year, so thank you. Whenever I see you at our national meetings, I think, wow, this little petite woman is so powerful, and I honestly feel pretty starstruck by you. So tell me, when you step on board a flight or you go out to dinner with your baby and toddler, do people actually come up to you and think you're a thoracic surgeon and that you're doing all this innovative, great work in lung transplantation?
Oh, most certainly not. I'm pretty sure when the average person sees me, they're just like, oh, look at her. I'm glad she got her like clothes on straight today because there's a toddler and an infant around her. But no, I don't. I think that's one of the nice things about our jobs, though, just as physicians in general, is that we get to do these amazing things at work, and then we leave the hospital and get to be fully immersed in our family life, and that's really nice.
How did you go from an initial interest in college, learning about a CABG or bypass surgery on the heart, to really being a pioneer in lung transplantation? What took you over that bridge?
Yeah, so I didn't actually I actually had no interest in lung transplant when I started my training. But I trained at WashU in St. Louis, and they're just the mentors both in abdominal transplant and in thoracic are just absolutely fantastic. And so, um, between spending 3 months on the abdominal transplant service and then working with all of the amazing people at WashU, particularly Dr. Patterson, and I know that Dr. Kreisel and Dr. Puri are kind of running the program now, and just working with them so much and doing transplants with them. I really just enjoyed that sort of ability to instantly change someone's life. And I know we do that with our general practice anyways, but it's so striking in transplant in particular, where these patients for lung transplant, they can't breathe, they can't do anything. That feeling we get after we run and you are just like, I can't do anything. That's how they live their life. And then you do a surgery and suddenly they're off oxygen. Their color changes. They can take a deep breath. They feel like a whole different person, and they can live their life in a way that they thought they wouldn't be able to again. And so that's what I really loved about it. And that's why I went into doing lung transplant in addition to general thoracic.
Yeah, in follow-up, I remember when I was in fellowship and I saw the new lungs inflate for the first time in that nice pink, beautiful color. Do you still get that rush when you see the lungs ventilate after you sew them in?
I still love it when you pick it up and you inflate the lungs and it blows up like a big pink balloon. It's quite special.
I love
Can you tell us a little bit about the transplant tradition at WashU? I know you said that it influenced you heavily to go into transplant, but tell us a little bit more about the culture, the history, and all of those things that sparked your interest in training.
Yeah, so the first attempt at lung transplant was in the 60s, I think by Dr. Hardy, but then due to just lots of technical issues and issues with immunosuppression, it really wasn't successful for a very long time. And then in 1983, it was actually Joel Cooper and Alec Patterson that, through a lot of work with immunosuppression and animal models, looking at how to sew the bronchus and things like that, they actually did do the first single lung transplant. And then they continued to innovate and continue to push, and in 1986 did a double lung transplant. And they really were the pioneers that kind of helped lay all the groundwork for where we are now. And then at some point, Dr. Cooper actually moved to WashU. And shortly after, I believe Dr. Patterson followed him. So by the time I started, Dr. Cooper was no longer at WashU, but Dr. Patterson was division chief of CT surgery, and everyone in the thoracic division really had been mentored by him. So all of the faculty had actually been trained at WashU. They were all WashU fellows, and it was just a really great environment to work in. I think one of the highlights of WashU is not only that they're um, clinically excellent at lung transplant, but they also take such pride in teaching fellows how to do it and letting them participate in the operation, learn how to do it, and become, you know, very, very good and proficient at it. And I think that just having that overall um, framework for training and was fantastic. And then, I didn't know any of the history until I was fully in thoracic surgery, and then learning the history just made me appreciate it even more.
So it's easy to get swept up in the history and the energy of a service like that. Did you ever hesitate and say, I don't want to do this. This is something that isn't interesting or isn't worth it? Or did you ever have any hesitation along the way?
I did not, and I know that transplant, it's actually changed so much even in my short time as an attending. But it is much more disruptive than just having an elective schedule, and I knew that, but I love beyond just the patients and the physiology and that. I also really just love the technical aspects of the surgery. And for me, I did have a quite an existential struggle of, loving that technical part. Do I want to be a cardiac surgeon? That was actually what I was trying to figure out is I love the oncology of thoracic. I love the patient population and the robotics, but I love the like technical challenge that is cardiac surgery. And so lung transplant was really this beautiful blend where I could still do, the complex sewing and things like that, but still get to do oncology and robotics and all the other things that I enjoy.
Dr. Chang, you talk about the changing landscape or the changing ways that transplantation is going. I know that a lot of centers are scheduling transplants, for 7 a.m. and it's not an all-night career specialty. Can you tell us a little bit about how transplants changed in the last 10 years, just for our listeners who may be interested in it?
Yeah, so I think when we think of transplant, you traditionally think there's a donor, it's scheduled at a time, your whole life, you drop everything that you're doing, and now you go in and it's whether it's 7 in the morning if you're lucky, but generally like 5 p.m. at night, 2 a.m. in the morning, some inconvenient time, you have to go in and do the transplant. And um, things are changing on multiple fronts. Some of it is we are starting to have more donor centers to help with donor optimization and improved organ yield. So that kind of helps with more appropriate timing of ORs. But in particular for lungs, um, you know, we now know that you can actually put lungs in a 10-degree fridge. And there's some science, I don't know how much I believe it. There's some science to suggest that there's actually remodeling that occurs where perhaps even putting it in the fridge and letting the lungs wait can actually help the organs recover as opposed to sewing it directly in. I don't know if that's true, but what has definitely been proven is that that 6 hour window that we had before, where you have to get it in and reperfused in 6 hours, we don't have that anymore. So now it's 12 hours, 18 hours, 20, I think 24 hours is our standard right now that you can go up to. But some people have even pushed beyond that and still have really good outcomes. And so with that, it gives you a little more flexibility where, okay, if they're insisting on a donor midnight OR, you don't have to go in the room at 3 in the morning. You can go in the room at 7 in the morning and do daytime surgery. And there's also lots of publications that show mortality is better if you do transplants during the daytime. And having a well-rested team for something that's complex actually leads to better outcomes. So it is changing. Um, it's changing the lifestyle associated with lung transplantation.
I really love that. And I don't know if I ever have shared with you, but early in my career, when I first graduated from fellowship, one of my mentors was directing me to be a lung transplant surgeon. That was what he wanted me to do. And so in those days, we didn't have interventional pulmonary that did all of our bronchs and stents and all that. So, I spent days taking care of all the transplant surgeons and days doing rigid bronchs and stents and all this. And then when I was pregnant and 8 months pregnant, we were flying all over the Southeast US, Midwest, getting lungs. And there were several of those middle of the night trips where I just thought I was going to die for sure, like pregnant with kid. And so then I never did another transplant again after I delivered my daughter, my first daughter. And so, I think that we all look at transplant now and say, wow, people can really do this job and have families and babies. And I know that you do. So, how do you rotate and evolve your home life with your transplant career?
Um, it is It is not the easiest. I wish I could say it was the easiest thing in the world, but a lot of it is having a really supportive, understanding partner. I met him shortly after I became an attending, so there's no, oh, you changed your career on me. Like he knew what my hours were. Actually, he met me when COVID hit New York, and I actually went to work every single day through COVID because we managed the ECMO, we did all the bronchs, we did all the trachs. And then shortly after that, I actually became the only transplant surgeon, the lung transplant surgeon for quite a bit of time. So was on call for the first 2 years of our relationship. And so he very much knew what he signed up for. And we really wanted children and we agreed on it together. And he knew coming into this that, some days some days I still get that like 3 hour notice and it's like, hey, like we're going to do a transplant now because that's the time that works. You have to pick up the kids or drop them off or do whatever. And so it requires a lot of coordination, a lot of communication, and help, for the beginning when my children couldn't go to daycare, my mom was here to help. But I know a lot of people hire people. I'm lucky enough where we're doing it with daycare and the two of us, but um, it's a work in progress, but we're making it work.
I have a question about your deciding to do transplant, and you said it's kind of this happy place between thoracic and cardiac. So for people who are interested in transplant, I have a lot of people who are trying to weigh doing cardiac and having a practice simultaneously, or thoracic and having a simultaneous thoracic practice. And how do you make those decisions, and how much control do you have as, a graduate of a program to shape your career in that way?
I think that So in terms of the last question first, if you want to do lung transplant and you truly want to do it and you're interested, I think you have so much power in shaping your career because there's such a shortage of lung transplant surgeons. So I can think of probably 8 jobs off the top of my head right now where a grad could go to. So I think um, if that's what you want to do, you should pick the other part of your career based on your interest. When I look at who's going to come be a partner here, I don't care if your other side is cardiac or thoracic. Do we have to have some room for you so that the other part of your career can grow? Absolutely. So that is where you have a problem, where you have to pick between all the different job options and figure out, okay, if you want to be a general thoracic, who also needs the general thoracic. But I know there are a lot of places that say you have to be a cardiac surgeon to do lung transplant, or you have to be a thoracic surgeon to do lung transplant. I don't think that's true. I think it's whatever you're interested in. And so long as other elective practice is something that you want to do and you want to do lung transplant, you'll be successful at both.
And for you, what has been the makeup of your practice, and do you see that changing in the future?
So I have a full elective practice. So I have my four, I guess for me full, so four robotic cases a week. I have 2 days of clinic, and then I have a transplant clinic as well. And then I have all the, call responsibilities between thoracic and lung transplant and all the add-ons that come with that. I really like my current schedule. I get to do um, the normal thoracic electives and um, have that patient population, which I really, really enjoy working with. And then I run the transplant program on the other side. And right now we're down to 2 people, so I'm on 2 out of 4 weeks a call for lung transplant. Um, I don't really see it changing, at least for the next 5, 10 years. At some point, I know everyone tells me, oh, you're gonna want to stop doing as much lung transplant and focus more on your elective at a later point in your life. And maybe that happens, or maybe the field continues to grow and change and we can shape it a little more, and I'll keep doing this till I retire. That's the plan.
That's great. I saw last year when I was looking at social media that not only have you been so successful in your career in terms of innovation and the first robotic transplant, but you were named in Time magazine as a top 100 rising stars of medicine. So I guess I have a couple questions related to this. I'm wondering, one, what your family thinks of all your success so early in your career. And then I'm wondering if your mentors actually reach out to you and say, hey, can you come teach me how to do robotic lung transplants?
I think from a family standpoint, my family, both my husband and my parents and my brother are probably like my biggest supporters. So to them, when I'm like, oh, I did this, they're like, of course you did. That's awesome. Congratulations. Um, they're very, they're happy, but they're not like surprised, like, oh, I never thought you'd ever amount to anything. Like they're actually very just like, of course, congratulations, supportive, happy. And so again, I'm very lucky for that. As for the mentors reaching out, I've definitely gotten, texts and emails and communications from them for all the random milestones, I guess, that have happened over the last couple of years, and it's been great. I I don't think any of them have quite reached out to ask me to teach them how to do a robotic transplant, but also they did teach me how to do transplant and robotic surgery, so I could see why they wouldn't ask me how to do that. But we do, I do see them a lot at all these meetings, and we talk, and we still have a great relationship. So yeah.
How do you how do you get to that mindset where you definitely have the skill set for robotic and transplant, and why not just keep things stable, safe, and do what you know how to do and do it really well? What motivated you to have the courage to try something new that could potentially, uh, you know, have an adverse outcome?
Yeah, no, that's a great question. And for a while, I really was thinking, I know how to do an open lung transplant. Why would I change it? And wasn't really like when I had initially heard about robotic transplant, because the timeline for it, just so everyone knows, is that in 2021, Cedars-Sinai, they were doing their minimally invasives through like bilateral anterior thoracotomies, and they were having trouble teaching fellows how to sew because they couldn't see. So that's when they started docking a robot through the open incision and sewing the lung in. And then the group in Barcelona actually did a single robotic transplant in early 2023, and they were really the only two that had done it. And so I'd been hearing about it for a couple of years, and I thought to myself, like, that seems a little silly. What's the benefit? And I wasn't really forward thinking because I was still at that point still pretty young in my career and just trying to get the NYU program like established, have our good outcomes, make sure that we're maintaining our volume and making sure again like patients are safe, things like that, et cetera. And so then um part of it was just I had gone through all the steps in my head and I was like, how do I clamp the vessels? And just seeing that there was a clamp, like a Vatsatinsky, really made it to me, that seemed like a huge barrier to overcome. But then when I was thinking about it and talking to a lot of people, like I'm very fortunate to be at a center that's super robot heavy. So Dr. Grossi and Dr. Lumet are world experts at robotic mitral. And like my partners, Dr. Cerfolio and Dr. Zervos, are the technically best robotic thoracic surgeons I've ever seen. And so between all of that expertise and all the things that we do, it actually seemed to me if there's any place that's really going to have all of the staff where our circulators, our scrubs, our anesthesiologists, the support from the OR, the ICU care, everyone, like we know all about this. We already do this every day. It's really just melding robotic cardiac and thoracic together. I thought if anyone had the best likelihood of being able to do it successfully, it would be us. And so that's really when I started talking to all the different surgeons and the staff and the OR, people in the OR, and just kind of figuring out what instruments do we need, what sutures, what are the steps, what are our ports going to be, because we did really change the ports to how we like to do it. And so it really was just thinking, if I think we can do it and I think we can do it well, and I think we have the expertise and that's why we started.
And what's the conversation with the patient, the first patient?
The first patient really, so we did 3 single robotics before we did the double transplant. And it really was, um, there's this new technique that's come about. I'm not sure if there is a benefit to it yet. It's very, very new. We are going to start doing it here. And so what we're going to do is try and use very small incisions to do your transplant. I did tell the first one it's probably only going to be on one side, not on both sides. And I made it very clear that if at any point it seemed like this was not safe, or if at any point I thought we should convert, like my threshold for going to a traditional open transplant was very, very low. But then also, the benefit would be potentially better recovery, less pain, because you will have a much smaller incision. And so we kind of discussed that, and um, pretty much every patient I've talked to about this has been very enthusiastic. And I would actually say I have to talk patients out of it because most patients ask for it. And I have to explain that we're still in its infancy. There's still a lot of heavy patient selection. And as we get better and the technique evolves, then we'll apply to more and more patients.
And what about the naysayers and the people who were, in the mindset that you were, that what's the benefit? And have you run up against negative perceptions of this technique?
Yes, absolutely. One thing I didn't mention that I do tell patients is to me, the benefit of the robotic surgery is if you're in that 85% of patients that do great after transplant and you get extubated soon, you don't have primary graft dysfunction, you go home within a couple of weeks, and so your recovery is faster and better. But I also make it very clear that the hardest part of lung transplant is the complication of primary graft dysfunction, right? And so if you have primary graft dysfunction, it doesn't matter whether I did your surgery open or robot. Your recovery time and your complications are all driven by how does that lung recover. And so for those patients, again, we can't 100% predict them, but for those patients, it's not as helpful. And so that has a comment I have gotten before where it's like, sure, robotics makes sense for general thoracic surgery where pain was the problem, thoracotomies and thoracotomy pain syndrome, and recovery from that was the hardest thing. But with transplant, that's not true. And I agree with that. And I don't ever think we'll get to a place where almost every transplant is robotic. But I do think that 50, 60, 70% can be done robotically in the future. The redos, the hard ECMO bridges, the sarcoidosis, the silicosis. I think there's always going to be a role for open, but for a majority of patients, um, I think this is going to be a technique that's adopted, and I think it is going to help them with their recovery and their pain.
Dr. Chang, it's pretty remarkable when you think about where lung transplant has come just in my career from the huge double clamshell thoracotomies, wound vacs, all these things, right, to robotic lung transplant. Have you seen a change in patients coming to New York or getting on your wait list or institutional volume since all of the press came out about the first robotic lung transplant in New York?
I think there's been a handful of patients that have come because of it. I will say one patient came from out of state to talk to me about it because they saw a news release and on the airplane had a very significant drop in their saturation. We were like, you actually can't get on a plane to leave New York anymore. Like you actually have to get admitted and just due to severity of illness did not get a robotic transplant. But I definitely have had a couple patients come just for that. Some of them are candidates, some aren't. I will say there is one patient that comes to mind that really didn't want a transplant until the robotic was an option. And thankfully, they are a candidate for it. Um, but they weren't really willing to consider it the old way. So I do think there might be some increase in recipients because of it.
This is a little bit of a hard question, but already transplant is not available in all communities. And for all people, it may not be possible to get to a transplant center. And then the added technological demand of the robotic technique, do you feel like this poses more barriers for people to access transplantation? Or, what's your impression about?
Yeah, I think I, I would say as of right now, like 99% of transplants are still being done, more than 99% are still being done open. And I will say the thing is the robot is an option, right? But even when I consent someone and say you're a candidate for a robot, there's this giant asterisk of depending on resource availability. So if I am giving a talk and there is an organ available at at that time, we're not going to delay their transplant or say no. They're going to get an open transplant, right? If the person that's available doesn't know how to use a robot. And I think the most important thing if you're a transplant recipient is you should go to the center that you can go to and get access and get good care and get the organ. And I think the robot maybe in the future for certain patients, if it's only available at a certain percent of centers, at some point, if there are frail patients that really need a robot not open, maybe then there will be some disparity and there will have to be figuring out how to get dual listed and it will be resource intensive for that patient. But the hope is that 10, 15 years from now, most centers will have a robotic transplant surgeon and it will be relatively available at many places.
I think it's amazing that you've not only developed this technique, but you've already thought about these challenges and how to implement it and disseminate the technology for the future. And that's a huge sign of leadership in the field, and I definitely commend you for that. And this leads me to my next question about you are a leader in the field, and our whole profession has few women. How do you see your role in mentoring other people? And it's among all those other things that you need to do: run your transplant, go to call, manage your family. Where do you fit mentorship into your life?
Yeah, I will say there, like you mentioned, there's very few um, women in CT surgery in general, as we all know, and actually none of my attendings were women in training. None of my thoracic attendings were women in training, and so I do think it's important for me to be a mentor for obviously all people interested, but I think it's also important to be a role model as a woman and as a parent. Because again, I wish I could say I haven't heard this, but even as an attending, a young attending now, I've had people make comments about, oh, it's different if you're a mother, your priorities are different, or like other random comments that I will not repeat right now. And I think it's very important to be accessible to anyone that really wants to talk about career development or how do we do it. I actually think a lot of people ask me, mostly people are asking me, how do you do thoracic and lung transplant? Because I guess people are told that's very hard to do. Um, but for all the female mentees and the ones that I meet a lot through the WTS, so for all those mentees, I think just being able to talk to them about what it's like and that you can still meet a partner, have a family. I wouldn't say have it all because that's a little difficult to do, but to have a nice balance and to still be able to achieve and still enjoy your family. I think that's really important.
So you heard it here. If you're at a meeting and you see Dr. Chang, introduce yourself. She has time. She wants to meet with you.
Yes.
At STS.
At STS, at STS.
Organ procurement and transplantation it's a difficult, challenging field for so many reasons, right? But I think the emotional toll that it takes is really difficult, and people don't actually talk about it in the open at our meetings. But I remember feeling great joy for the patient that was waiting on their transplant, and then horrible grief for the donor's family at the time of the procurement. So, what do you do to unwind, Dr. Chang? What's your release that you can, get through the tough days and the tough procurements?
Um, yeah. The tough procurements are hard, and you know what? It's always the young patients, and it's either an accident or worse, self-inflicted, and then it's really difficult. And I think for me, I try not to focus on it. It does cause like all of in addition to just feeling terrible for the donor, you then just wonder about all the things that could happen in your life with your children or the people you know. And but for me, I think just focusing on, the organs went to save someone. I know the recipients, I know them, I meet them and their family, and just seeing how well they do afterwards, that's what gets me through it. And a lot of it is just I go home and I hang out with my family, and you know, when you have children screaming at your face about Legos, it does take your mind off of other things.
What else do you do for yourself to take care of yourself?
Um, I really enjoy reading. I like to read books. And I like to just really, I'm very, very simple. I like to just hang out with my family at home. And then my husband and I like to go and try out the food scene in New York. And that's my life in a nutshell.
And read books, not audiobooks, not
Oh
Kindle.
no. Oh no, I like to physically read
It
books.
has to be, is your house filled with books?
Yeah, I have to donate them every year because I run out of bookshelf space. I'll read on Kindle, I'll read on my phone, but there's something just so nice about like a paper book, you know?
Great. Well, we're in the midst of a snowstorm on the East Coast here, so you deserve some time alone with a book to unwind. And I just wanted to thank you on behalf of Sara as well for being a part of this conversation today. We're so grateful that you joined us. We know how valuable your time is, but it's so important for everyone to hear your story and to learn about what drives this incredible innovation and practice. So thank you so much.
Dr. Chang, thank you so much for joining us today. I am excited when I'm retired in 10 years to listen to this podcast again and hear what you're going to do next in the world of transplantation. And you'll look back and you'll say, everybody's doing robotic lungs. Now we're doing ... So
Yeah.
thank you.
No, thank you for having me. This has been great. And hopefully in 10 years we're like, oh, look, robot transplant's so easy. What were we talking about?
And we're hoping there's a cure for graft rejection, right?
Great.
So,
That would be even better.
yeah.
This has been Same Surgeon, Different Light, a podcast brought to you by the Society of Thoracic Surgeons. Thank you for listening. If you like this podcast, please rate it 5 stars and let your friends, trainees, and colleagues know about it. On social media, you can use the hashtag #TheFaceOfCT Surgery. And for more information about the Society of Thoracic Surgeons, you can go online at sts.org.